Okay, hello and welcome to this Goodfellow webinar on type 2 diabetes in young people, which is kindly supported by Pharmac. My name is Vicky Mount and I'm a GP registrar out in Manorama in South Auckland, and tonight I'm talking to Dr. Stephen Miller, who's an endocrinologist in the North Shore with private practice on the shore as well. And now I will hand over to Stephen to get started with the discussion. So over to you.
Great. Thank you, Vicky. And I'd just like to say thank you for giving me the opportunity to deliver this webinar. It's the first time I've participated in this format. Hopefully I can do it justice. So I don't have any relevant conflict of interest for this presentation. Presently in New Zealand, there are just under 250,000 individuals who have diabetes. These are data presented on the Health Quality and Safety Commission New Zealand website. You can see the URL there, and they're put together in conjunction with the Virtual Diabetes Register, a project that's been running with the Ministry for a few years now. It's worthwhile clicking on that link and just having a play with the data. You can look at your particular health board area and see how you perform in a number of different ways relevant to diabetes. There are between 3.9 and 7.6% of individuals in each DHB affected by diabetes. Looking at the top right panel on the slide, you can see that certain ethnicities, in particular Pacific ethnicities, have around double the prevalence of diabetes compared with Maori, Asian or other. And if we look at the age, diabetes is predominantly an illness that does affect older people, with really only a small number under the age of 24 affected, and this progressively rises such that in the over 75 age group we've got between 15 and 20% affected. Now, one of the limits with these data is that it includes both type 1 and type 2 diabetes. We're not able to subdivide from there, so I can't identify which individuals represented here are affected by type 2 diabetes. That's one of the limitations of this data set. In years gone by, when I'd be talking about the pathogenesis of type 2 diabetes, we'd be talking in a very basic way about a combination of insulin resistance, both at the level of the liver and also in the muscle, and also some form of beta cell defect, an insulin secretion defect, leading to hyperglycemia and the constellation of features we now recognise as type 2 diabetes. I quite like this approach from Ralph DeFronzo's group. They're in the States and one of the predominant groups describing pathogenesis. And they're talking about the ominous octet, now recognising that we've got defects present in the alpha cells with respect to glucagon secretion. We've got brain defects, there's renal abnormalities, changes in adipocytes, and also the crosstalk that exists between the pancreas and the gut, the so-called incretin hormones, all contributing to hyperglycemia. And one thing I'd like to always try to remember is that almost no two people with diabetes have the same disease. We all have the same common pathway that is hyperglycemia, but we have different contributions in a relative sense of all these different defects. Type 2 diabetes in young adults is basically the same in terms of pathogenesis as it would be in the diabetes we recognise in our older adults. The only difference here is that these things are happening much earlier in the lifespan. Like more conventional type 2 diabetes in older adults, obesity is the principal risk factor leading to diabetes risk, and the rising incidence of diabetes in young adults globally mirrors the increase in obesity. These data come from the OECD, from their website. The URL is indicated there, and on the left hand side we can see New Zealand really up there in terms of the heavy hitters with obesity, all the countries stacked up, with Japan at the top with only 3.7% obesity amongst adults in 2015, with the United States up at 38% of adults suffering from obesity. In New Zealand we're up there 30.7%, which is not something that we should be proud of. This is certainly contributing to diabetes risk. The top panel on the right-hand side looks at the overweight and obesity rates in children at the age of 15. And in all the OECD countries, there's around 15%. The New Zealand data aren't on that slide, but it's worrying that up to 30% of children age 15 or teens in the United States are overweight or obese. And the lower panel on the right just shows the predicted rates of obesity over the next couple of decades, indicating that we really are by no means, the obesity epidemic is by no means over. I think we can expect to see far more adolescent and young adult type 2 diabetes as a consequence of this epidemic. In all patients with type 2 diabetes, we recognise that family history is a very important contributor. The Framingham Offspring study, published now nearly 20 years ago, demonstrated that offspring of an individual with diabetes will have around a 3.5 times higher chance of having type 2 diabetes compared with controls by the time they hit late adulthood. And that risk is increased, close to doubled, by the time both parents are affected by diabetes. But if we look at the data from the Today study, which was looking at newly diagnosed young adults between the age of 10 and 17, again in the United States, with type 2 diabetes, 60% of those participants had a first degree relative affected by type 2 diabetes, and it was almost all of them, 89%, when grandparents were included there. So a very, very strong association, and arguably stronger association than we would expect to see in our older type 2 population. As I alluded at the beginning, with the observation that the Pacific ethnicity in New Zealand have a double prevalence of type 2 diabetes, the same can be said with other ethnicities across the world. Particularly well studied would be those Aboriginals within Australia, the Native American Indians, but a number of other ethnicities have a very strong diabetes prevalence. Maori more prevalent than New Zealand Europeans, Pacific greater than Maori, and the other in the Indian ethnicity in New Zealand is another very high prevalence rate. We have yet to decipher exactly what the genetic contribution is there. We understand that there's a polygenic contribution of risk, and it's the contribution of those risk alleles present in the founding populations. Female gender gives an extra risk of type 2 diabetes that we don't necessarily see in our older populations. So in young adults, girls have between 1.3 and 1.7 times increased chance of developing diabetes. And the theories for this have included a role for polycystic ovarian syndrome, which I think of as a spectrum disorder prevalent in a significant number of women. And this, of course, has the common underpinning factor of insulin resistance. And clearly there's a link there with type 2 diabetes pathogenesis. The other factor, which is gaining momentum and I think is, for me, probably more thought-provoking than anything else, is the concept of metabolic programming. And that is championed by colleagues with fine research coming from the Gluckman group and others in other departments in the University of Auckland, showing that if we look at the graph here on the bottom right, these are quartiles of ponderal index along the x-axis. That's basically an equivalent of BMI, so it's weight for length at birth. And then the coloured bars indicate the achieved adult body mass index. And we can see, looking at the group with the lowest ponderal index, the strongest association with having an obese BMI or an overweight BMI greater than 28, suggesting that small gestational age, and that can be associated with poor maternal nutrition, or in fact gestational diabetes in the mum herself, is associated with abnormal metabolic phenotype once that child reaches adulthood themselves. The other aspect, of course, is that gestational diabetes begets gestational diabetes, and we know that over and above the genetic contribution, offspring born to mums who have gestational diabetes are far more likely to experience the same condition. There are a number of other contributory factors. In normal kids who don't have diabetes, insulin sensitivity is reduced by up to 50% at puberty, largely driven by growth hormones and also sex hormones at onset of puberty. And this, of course, is if you have a metabolic background, this can be enough to push you over the edge from normal healthy metabolism towards pre-diabetes and in fact towards diabetes. And this, I think, when we get resolution of diabetes and an apparent improvement in some, not all, that probably is explained by just the change after coming through puberty and that hormone excess resolving. Anybody who's got teenage kids knows that their diet isn't perhaps always as we would recommend. They don't participate in physical activity as we would like, and certainly sleep and stress scores are all markedly abnormal in youth, and it's certainly also seen in youth onset type 2 diabetes. And one other consideration that I do like to point out is that these young people are fertile. These young people are also having sex, and so we do have to think about perpetuation of diabetes risk in offspring. With pre-gestational diabetes, there is a markedly increased risk to both the mother and also to the fetus, and optimization of the metabolism before pregnancy is by far preferable to dealing with the consequences of an unplanned pregnancy.
I wonder if I can just interrupt you briefly with a question about the risks. If both parents have type 2 diabetes, chances of child having type 2 diabetes, are there any, type 1 diabetes?
Type 1 diabetes. So the data for this are different. Type 1 diabetes, of course, being a very different pathogenesis. We've got autoimmune mediated, T-cell mediated destruction of the insulin producing beta cells in the pancreas. If we look at mums with diabetes, an 8% risk springs to mind, 12% with dads. Can't explain why it's slightly higher with fathers. And they're based on UK data. I have read other data sets which suggest a much lower association, and I can't remember seeing anything that's higher. So I think there is a difference in different populations, just the same way we see different prevalence of type 1 diabetes and other autoimmune conditions in different populations.
Sure, that makes sense. Yeah. Also, just a quick question about defining, I think, HGP. It was on maybe the slide with the octet. Perhaps was that have been
Goodness,
there?
if we can go back to refer to that.
Is there something on
Increased hepatic glucose production.
There we go. Thank you. Acronyms. They confuse us all.
Sorry about that. Yeah. I should have explained that. Right.
Thank you.
Okay, so if we can just move on then. I think one of the things that doctors, nurses, healthcare professionals are very guilty of when we're talking to any individual with diabetes is we're being very glucocentric because we are goal-driven people. One of the things we forget is that it's not just all about the glucose. And I'd like to draw attention to the comorbidity with other often age-associated cardiovascular risk factors that we see, unfortunately, with a high prevalence in our young adults with type 2 diabetes. Depending upon which studies you look at, and again, I've quoted the Today study of newly diagnosed type 2 diabetes in US adolescents aged 10 to 17, around 10% of those individuals had elevated blood pressure at diagnosis and entry into that study. And that was within 18 months of diagnosis, they had to be included. And by the time that study ran, 30% had elevated blood pressure. The thresholds for diagnosis of hypertension in this age group are the same that we would use in the clinic for our adults. And in a high-risk population, those with diabetes, we aim for a target blood pressure of around 130/80 or slightly below if we can. Just as in our adult patients with type 2 diabetes, ACE inhibitors, or if they're not tolerated, perhaps due to cough, an angiotensin receptor blocker would be first-line therapy. After a limited trial of lifestyle advice would be moderating salt intake, hopefully not alcohol intake in this population, but it's always worthwhile having a conversation about it, and increasing physical activity alongside weight loss. In my experience in the young adult population, that is generally not an effective strategy, and for a number of reasons I tend to strike while the iron is hot, and I tend not to be as lenient. I think it's something that we're very guilty of thinking, making excuses for the patient. Oh, you were late, the traffic was bad, I kept you waiting in the waiting room, etc. Excuses for blood pressure not being at target. These young people are at risk. They've got a lot of life ahead of them. We know that they have accelerated complication rates, so I like to treat them early. It's not always an easy decision, and I might make the decision to treat long before the patient accepts that.
Sure. Yeah.
And that's maybe something that we can talk about.
Any ideas what proportion of people would have hypertension? I mean, you've sort of alluded to that here at diagnosis, roughly 10%. Does that sort of align with your experience of what you're seeing in New Zealand?
I think I see a skewed population.
Of course, yeah.
I tend to see those people who often have a longer duration of disease and already accrued complications of that. So I think I see a higher prevalence than that. These young adults who've got type 2 diabetes in that adolescent age group tend not to be referred to my specialist clinics. I would love them to come to see me in the clinic. And often they're referred, but they don't come. But I think there's also a group out there who are not referred. So, these are challenges. But the other thing to say is this is a US population with their ethnicities. We do know that our Maori Pacific patients are more susceptible to hypertension and also more likely to develop downstream complications of hypertension, especially with renal disease, which we'll come to talk about later. So there will be subtle differences.
Sure.
But please don't forget about the blood pressure.
Yeah, absolutely.
Blood pressure is somewhat easier to deal with, though. It's something that's much more tangible, and I think we can all associate it with vascular damage and see the benefits of treating. Lipids are somewhat more abstract. In the Search for Diabetes in Youth study, published a few years ago now, but again an American cohort, between 20 and 30% at diagnosis of type 2 diabetes had dyslipidemia, and they compared in this particular study the prevalence of these complications in type 1 and type 2 diabetes. So 1.5 times more had dyslipidemia than the type 1 population. And they've also demonstrated in the Today study a rise in these lipids over the first few years of diagnosis. And that's not something that I would recognise in type 2 adult patients. Right. So these lipids are getting worse and worse in spite of treatment often. And the reasons behind that are not entirely clear.
In spite of diabetes treatment?
In spite of diabetes treatment. Now, coming to treatment of the dyslipidemia, there are no prospective data to support the use of statins in this age group.
Right.
The cardiovascular event rates, of course, are so very, very small, and so the numbers needed to treat would be enormous. A study published in the New England Journal within the last couple of years demonstrated no benefit of treating individuals with type 1 diabetes with lipid lowering and ACE inhibitor with respect to a renal endpoint. It's intuitive that lowering cholesterol is going to help, but I actually don't treat cholesterol unless it's somebody who has a very clear inherited dyslipidemia of other family members affected with very strong history of premature cardiovascular disease. The other group that I do tend to treat, in fact I saw a girl with this condition this morning, is those who've got a very high triglyceride level.
Right.
This 18-year-old girl who'd had type 2 diabetes for 6 years, had ignored her diabetes for 5.5 of those years, had triglycerides of 53, and had her third episode of pancreatitis, bringing her to hospital. Gosh. And I saw her this morning. So they're the other group who we do treat. Yeah. Okay. Not because of the cardiovascular endpoints, but because we know we can prevent the pancreatitis by lowering the triglycerides.
Sure. And is there any evidence, it's a question just about whether or not you would consider starting a statin perhaps roughly 10 years after the diagnosis in the manner that you might think about with other populations, even if the lipids are normal?
So there would be no RCT evidence to support that. I think this is where the art of medicine it will trump what the data demonstrate. If I have a younger adult who has clearly a number of risk factors, they have a terrible family history, we all know the trajectory this patient is on. I'm going to, as their physician, I'm going to try to minimize the impact of their metabolic trajectory and lower their cholesterol. I can't show you the study to demonstrate why that's going to work. Maybe I'm treating myself, but I think
the individual risk assessment.
Individual risk assessment.
Exactly. Yeah, sure. Okay.
Fatty liver disease is often something that we overlook, and it's well known that young adults also have evidence of non-alcoholic fatty liver disease, whether it's NAFLD or non-alcoholic steatohepatitis. these patients will benefit from weight reduction. Use of a statin is not necessarily going to help the fatty deposition within the liver. What will work is use of a thiazolidinedione, and that's one of the things that we have in our armoury to treat pioglitazone in those individuals who do have the elevated transaminases, the hepatomegaly, the ultrasounds that demonstrate fatty infiltration. I use pioglitazone, and I've got a few patients on that, and it works.
Great. With regard to the triglycerides, just a couple of questions about your treatment of choice. Someone specifically wondering if you have a preference for statins or fibrates.
Okay, so my normal pathway would be, these patients are sick, they've got acute pancreatitis, these are in hospital. Especially for example, the young lady I saw this morning, triglycerides of 53, an insulin infusion will bring that lipid profile down very, very quickly. The insulin switches on lipoprotein lipase in the adipose cells, and that very quickly clears the triglycerides from the circulation. And I would expect at least a 50% reduction within 24 hours.
Oh, right.
Very, very quickly indeed. While they're an inpatient, I will start them on atorvastatin. I would typically choose a dose of around 20 to 40 milligrams. I'm not going to go right in with the top dose, because I will also use a fibrate in the short term. Combination of the fibrate with the higher dose statin is more likely to give the side effects. And so I don't elevate the dose of both straight away. I find that in an ideal world, we'll treat with the insulin, control the diabetes, that brings the triglycerides down, get the statins on board, and along with the fibrate for the first 3 months, and then usually drop the fibrate and keep them on the statin.
Right, got it. Okay, thanks, that's great. Just check, we had, so I think we had a couple of questions about that. Just for clarity as we go through, age group that we're talking about in terms of young adults, what would your upper limit be? Just while we're...
I knew I was going to be challenged on that. The evidence and the literature seems to include people up to around the age 18. I think that's based on mostly North American insurance company cutoffs.
Right, okay.
For us, we tend to see transition patients maybe around 15, usually 16 onwards. But, you know, it's a spectrum of disease.
Sure, okay. I think that's probably... just a question about the use of pioglitazone. Place for it with an obese patient with fatty liver but not diabetic, would you consider?
Good question. I probably wouldn't in that context.
Right.
We have to be cognizant of mechanism of action. This is a drug which does not have one discrete molecular target. It's affecting transcription factor levels, so that's leading to increase and decrease of the activity of a number of different genes in numerous different tissues.
Right. Okay.
Some of that is beneficial. Other aspects of that may not be in the longer term for these younger people, half of whom are potentially going to be getting pregnant.
Yes. Sure.
So I in that situation would prefer to be very heavy on the lifestyle approach, encourage the weight loss, encourage the physical activity, the change in diet, because these things do work as well. Pioglitazone when you've got diabetes, but without diabetes and fatty liver, I would use lifestyle.
Sure. Okay, that's great. Thanks.
Okay. Now talking about the diabetes complications, I think everybody recognises micro and macrovascular complications of diabetes, and it is implicit that the risk of developing retinopathy, nephropathy or neuropathy is directly proportional to the degree of dysglycemia. In other words, the higher your average blood glucose is, or your hemoglobin A1C, the greater the risk of developing these complications. If we look at the type 2 diabetes youth cohorts compared to age, sex, diabetes control, hemoglobin A1C matched controls, we can see higher prevalence of retinopathy, close to doubling retinopathy, 3 times as much nephropathy, and a doubling of neuropathy risk in these young adults when they're followed up over 8 years. And this is a good number of data points. Most of them have type 1, but around 400 patients in this study had type 2. So significantly greater risk of developing microvascular complications. So I'd just like to emphasize that type 2 diabetes in young adults is more aggressive than type 1, and it's also more aggressive than type 2 diabetes would be in a similarly matched older population. So again, emphasize that we have a more severe phenotype, lower beta cell function at baseline than in adult type 2 diabetes in some studies, and in a number of studies, a more rapid decline in that beta cell function. In other words, the remaining beta cells that are there are getting lost, becoming metabolically sick and not responding the way we would expect them to more rapidly than in older adults with type 2. Higher prevalence of microvascular complications and also the cardiovascular risk factors at diagnosis, and a more rapid progression of those complications, and a stronger association with ethnicity, with deprivation factors. And I term this an accelerated form of diabetes, and one not to be taken lightly. Social determinants of health as defined by the World Health Organization are very difficult to address in a talk like this. We could give a whole series of lectures and still just scratch the surface. But in general, we often find that the youth with type 2 diabetes come from our lower socioeconomic classes. They have lower health literacy and often a number of other social challenges. I find them particularly difficult to engage. I've already alluded to that with patients who, even those who are referred to our clinics, don't often come, or they'll come once or twice and fall out of follow-up. It's lost. It's not just us that have that problem. Internationally, when you have real-world data from these experts, DeFronzo, etc., these bigwigs in the diabetes world, when they present their data about young adults, we're not necessarily doing any worse than they are. Even the individuals who go to their clinics often have very bad control, the progression of the complications that we've described, in spite of expert best practice. So I mean, that's making us feel slightly better, but it is a challenge to know exactly what we can do to prevent the slide towards the end organ damage that unfortunately is an eventuality in a number of these young adults. So screening for diabetes is something which is challenging for this population, and diabetes screening comes in primary care, I understand, as part of the cardiovascular disease screening. And in the at-risk populations, according to the newer guidelines, I think the youngest age is around 30.
Around 30, correct, yeah.
So we're going to miss the boat for these people, even with this, with the threshold coming down to a younger age group. The New Zealand Society for Study of Diabetes suggests screening obese or overweight children and young adults if there's a family history of early onset diabetes, again talking to that strong genetic link, and especially those of the high risk Maori, Pacific and Indo-Asian ethnicity. And the slide is one of my favourite clinical signs for looking at in the supermarket, and that's the acanthosis nigricans. I think whenever we see that, we should be thinking about screening for diabetes. Young adults who've got polycystic ovarian syndrome, and the few young adults who may also have an endocrinopathy, Cushing's would be rare, acromegaly very rare, but these kids should also be screened for diabetes, but that's really not something that's going to be seen very often. Acanthosis is going to be seen far more in people with a strong family history of diabetes, in obese and overweight kids, and they should be screened. So how do we screen for diabetes? Well, I can think of very few reasons at all why I would want to use a test other than hemoglobin A1C. Moved away completely from doing glucose tolerance testing or random glucose monitoring. Perhaps in the rare circumstance someone is transfusion dependent in hospital or on interfering medications or very iron deficient or has hemoglobinopathy, but these are really very small, specialised, unusual circumstances. So I think for most in primary care, just use the hemoglobin A1C. And the diagnostic cutoff for diabetes in adolescents is exactly the same as the cutoff for adults. That's great, it's easy to remember. If you're anywhere else in the world, it would be equivalent to around 48 millimoles per mole, but we rounded it up to 50 because it's easier to remember. We do slightly underdiagnose.
Okay.
But I like the way it works. 20 to 40 normal range, 40 to 50 pre-diabetes, 50 above is diabetes. In young adults with new type 2 diabetes, or new diabetes that looks like type 2, there probably will be more of those individuals who will actually have an autoimmune cause. There's considerable overlap between the two conditions, as we know.
Yeah.
And looking at published case series, we're looking at around a 5% incidence of autoimmune type 1 diabetes in a population who were previously thought to have type 2 when you actually look for it.
Okay.
So I would have a lower threshold for, when there's no family history, especially no family history, leaner young person, you don't have any acanthosis, I would start looking for your autoantibodies, thinking about that.
That makes sense.
The slide shows the prevalence of type 1 diabetes with age, showing that the incidence per 100,000 in the population that was studied here for type 1 diabetes is skewed more to the left of the slide, and we don't really start seeing many people with type 2 diabetes until they really hit that 10 to 19 age group. So it really does seem to be associated with puberty.
Yeah, sure.
Okay. Just another comment on the diagnostic threshold for diabetes. We diagnose diabetes at a threshold in at-risk populations above which there's an association with microvascular diabetes complications. So basically based upon your risk of developing retinopathy. That has not ever been validated in youth with diabetes.
Oh, really?
So we're extrapolating directly from adults to kids with no evidence to support it.
Gosh, yeah.
It's intuitive that it's going to work. But
yeah.
Just important to point that out.
Just a question as we talk about risks. Someone's asking if there's any data on African descent as applies to New Zealand. So African people born in New Zealand, whether the risk profile would align particularly with any of the other ethnic groups. I know they're not sort of identified as a particular group.
They're often, people of African descent are, in any of the data I've seen, either presented or that I've read, are grouped with the other ethnicities because there are simply not that many people of that ethnicity in our population here. I would probably, and this would be an opinion, I would probably compare them more with the African American data. That's the best data that exists. Larger numbers of patients that I would base their risks and their profile with and how they may respond to particular agents upon the African American experience,
that makes sense.
Rather than any other group within New Zealand. So sorry, I don't have any specific answer to that one. That's a challenging one. Pre-diabetes in youth, well, everything is extrapolated again from adult pre-diabetes. We don't have any prospective outcome data on pre-diabetes in youth. I like the concept that pre-diabetes is a risk factor for developing a risk factor. Diabetes is a risk factor for developing vascular damage due to hyperglycemia, and pre-diabetes is a risk factor for developing diabetes. It's not a disease state in itself. There's no strong data to support active treatment of pre-diabetes in terms of preventing hard events. We're not going to save kidneys, save sight, save limbs by treating people with pre-diabetes. If we look at an adult population, roughly a third are going to regress back towards a normal metabolism, a third will progress to type 2 diabetes, and a third will remain in the pre-diabetes range, broadly speaking. It's hard at the outset to predict who that's going to be.
So repeat monitoring is your friend there.
Exactly. I would suggest if someone's got pre-diabetes, I would do an annual screen with the hemoglobin A1C. Obviously, you can do that sooner should they present with osmotic symptoms or anything else to think that they may have progressed more rapidly. I would always give lifestyle advice. Whether that is actually going to help, you can debate. We can show data that shows either in a secondary or primary care setting. You can ask people to eat less, exercise more, and it makes no difference to any outcome. I wouldn't enter these individuals into a complication screening program. They don't need retinopathy screening. They don't need annual kidney blood tests and urine tests. They don't need their lipids checked. For some individuals, I might think about metformin, and that would be mostly the polycystic ovarian syndrome young ladies. There is some evidence that metformin, by improving insulin sensitivity in the ovary, can improve ovarian function. I don't believe that metformin really helps with weight loss. some individuals seem to respond in that way. It's probably not going to be harmful in that group. But for most people with prediabetes, I'm not going to treat them. Some people are tempted to, because in the diabetes prevention studies, they showed that metformin treatment, especially in young people with prediabetes, helped to improve their metabolism more than lifestyle alone.
Okay.
But those studies are difficult to reproduce in a real world setting because of the cost of the interventions. With the lifestyle intervention, it's very, very complicated and labour intensive and not practical for us to be rolling out in New Zealand. So the treatment of type 2 diabetes in young adults in New Zealand is very similar to the treatment of type 2 diabetes in older adults. I like to think of the foundation being our lifestyle advice with a healthy dietary approach with fresh produce, reduced processed foods, low glycemic index foods, more of a Mediterranean style diet. Reduced in macronutrients, really, there's not much evidence to support any particular high protein, low carb, high fat, etc.
We've had a question particularly on that, which I was going to wait for the right moment to bring up.
Always comes up.
So, in your opinion, no particular evidence one way or the other?
Not studied particularly in the young adult type 2 population, but in the general type 2 population, there's some data to suggest that there might be a slight advantage with the Mediterranean style diet when that's including extra virgin olive oil and lots of nuts. That's been reproduced, but there's no evidence to say that any other macronutrient diet, whether you're high protein, low fat, high carb, whatever, is going to be any better than the other. It's reduced macronutrient content overall that leads to the weight loss, which leads to the metabolic benefit on the whole. Physical activity, aiming for 30 minutes at least a day. Don't mind what they do, as long as they get hot and sweaty. They can be lifting weights, they can be running, swimming, really anything at all. And weight reduction, unfortunately, we don't have any safe or effective pharmaceuticals that I would use in this setting that's going to lead to a meaningful weight reduction. Pharmacotherapy to address the glycemic issues, well, metformin, the foundation upon which we build all other pharmacotherapy, and should be continued. Start with a low dose because of the GI side effects. I typically start 500 milligrams once a day for a week and gradually increase it by 500 milligrams on a weekly basis until we're achieving a target of 1 gram twice a day.
Okay.
If someone's very big, I might go to 1 gram 3 times a day.
Right.
But I'm not convinced that actually that's making much of a difference unless you're very, very big. For most people with normal kidney function, you clear the metformin very fast.
Okay. Right.
So we tend to get a bit worried with metformin and declining GFR. We don't tend to have declining GFR in this population themselves, but even with kidney impairment, we will still want to use as much metformin as we think we can. I think that's a situation where people should come in to see a specialist clinic and have involvement, both with their primary care specialist, also their hospital specialist.
Sure.
Sulfonylureas can be used. Always have to be careful about risk of hypoglycemia. And of course, with sulfonylureas, we have the risk of weight gain that comes along with that. So we really need to be heavy on the dietary modulation and the increased physical activity to try to negate the effects of the weight gain that we see with sulfonylureas. But again, most of these data are extrapolated from studies of adult type 2 diabetes. We can talk about the UK PDS studies and the reduced diabetes complications seen with metformin over and above any other glucose-lowering therapy. That hasn't been particularly studied or reproduced in a young adult population. So it's all assumption. Okay, first, you can click over. Thank you. Right. The Today study that I've spoken to about some of the characteristics of these patients, young adults with new diagnosed diabetes, type 2 diabetes, aged 10 to 17 in the United States. The individuals were randomized to 3 groups. They received metformin alone, metformin with an intensive lifestyle intervention, which was very intensive. It was 1 hour a week for the first 8 or 9 months, then going to 1 hour a month for the following 8 to 9 months, and then more follow-up with phone calls and face-to-face appointments for them and their families. So very, very expensive, very labour-intensive intervention. Or they were randomised to metformin with rosiglitazone, no longer available in New Zealand, but a PPAR gamma agonist like pioglitazone, an insulin sensitizer. And the primary endpoint of the study was glycemic failure, so a hemoglobin A1C greater than 8%, or in our scale 64, 65 level. And what we can see is that there's actually not very much to choose from between these studies. They spend lots of money and lots of time talking about diet and healthy lifestyle and exercise, take them to the gym, show them what to do, and it doesn't really add very much, not in a significant way. Slight advantage when we compare the metformin and rosiglitazone group with the metformin alone group. It's statistically significant, but probably not as clinically relevant. And the study can demonstrate that there's around a 50% failure rate of maintaining glycemic control in all three groups by around 3 years. So we don't see metformin failure or a less durable effect of metformin like this in our older adults with type 2 diabetes. Again, alluding to this more aggressive metabolic phenotype, it's more likely to deteriorate rapidly in spite of treatments that we would consider to be standard approach in our older adult patients. And the take home from this, I think, is that most young adults with type 2 diabetes will require combination therapy earlier than we may otherwise expect when we're comparing with our more usual older adults with type 2 diabetes.
I wonder if I can just interrupt you for a couple of questions that have come through, particularly about treatments. One here just questioning about sulfonylureas, and given the doubts about outcomes in adults with type 2 diabetes, how sort of confident can we be using them in this population?
Okay. Sulfonylureas undoubtedly are good drugs at controlling blood glucose. They will give us, within 3 months, when appropriately titrated, control of glycemia as measured with a hemoglobin A1C. I don't like using sulfonylureas though because of the weight gain that they produce and the risk of hypoglycemia. And I find that if there's no other complication of diabetes that any patient fears the most, it's having a hypo. People don't like hypos. Now, with careful education about their use and engagement of the patient, that can be avoided, but that's one thing that I'm concerned at. I think that whoever's asking the question, I think, is probably alluding to the outcomes from the Accord study, which demonstrated that probably an increased risk of cardiovascular death related to hypoglycemia with aggressive glycemic management in older adults. But these are people who had diabetes for at least 10 years and also had cardiovascular disease equivalent, so opposite end of the spectrum in terms of age, and also with more atheroma and confirmed large vessel disease. So I think slightly different comparison. As you'll see from the next slide, I wouldn't advocate the use of some of the more modern non-funded diabetes therapies, simply because the data isn't there yet. Kind of stealing my thunder from the next slide, we can maybe advance to that. The drugs I'm talking about now are the DPP4 inhibitors, the GLP-1 agonists, and the SGLT2 inhibitors, which I'm using increasingly both in my public and private practice. I've got large numbers of patients, a good experience with these drugs achieving great levels of glycemic control without hypos and with falling weight rather than rising weight. There's a very strong argument to get these drugs funded by Pharmac, and I've written to Pharmac on a number of occasions now. And I know that they're looking at a model whereby these drugs can be funded, in particular the SGLT2 inhibitors with their the EMPA-REG outcome study demonstrates with empagliflozin that there's a reduction in death from cardiovascular causes and a renal protective effect, alongside small reduction in blood pressure, 2 to 3 kilograms of weight loss over the first 6 months in drugs that are once a day and will not cause hypos. It's very hard to argue
It's appealing, isn't it?
for a better drug.
Mm.
GLP-1 agonists, especially the once weekly version Bydureon, is very expensive, but a once weekly injection leading to improved appetite suppression, good glycemic control, and the equivalent amount of weight loss that we would see with somebody on insulin gaining weight. So diverging curves, at the end of a year, somewhere between 3 and 5 kilograms lighter, when they would have been between 3 and 5 kilograms heavier had you used insulin alone. In somebody who's starting off with a body mass index in the obese category, again, it's a very appealing drug. And there are also some studies which would suggest cardiovascular markers go in the right direction with Bydureon, but no outcome data as yet. And the DPP-4 inhibitors, generally speaking, thought of as being somewhat weaker in terms of their effect. However, I recently was an investigator in a study that compared DPP-4 with an SGLT2, and the DPP-4 after 6 months actually had better glucose lowering than the SGLT2, and I'm quite surprised at that outcome. However, none of these have got any prospective RCT data for their use in young adults, definitely not in pregnancies. It would be off-label use, and I don't have any of my young adult patients on any of these agents.
Right. So not just now.
Not just now. I think we need to watch this space and be guided by colleagues elsewhere who have better access to the drugs.
Sure. Yeah. Okay.
All right. So one of the things I think is important just to cover off whenever I engage with primary care colleagues talking about diabetes is how I start insulin. There are many ways of doing this. We have, broadly speaking, 3 types of insulin. We have our basal insulins, that would be our Lantus or our isophane NPH type insulins. We have our mealtime prandial insulins, or rapid-acting analogues. And we have the premix insulins, which have a fixed combination of both types of insulin. And at the end of the day, it doesn't really matter which one we start. After 2 to 3 years, we reach very similar glycemic endpoints with subtly different profiles in terms of weight gain, hypos, etc. I like starting a basal insulin, and I think that certainly the Auckland primary care health pathways will point towards using a basal insulin first. I like it because it's easy. It allows the patients to go at their own pace and build confidence with self-titration. So when I make the decision to start insulin, and that will be somebody not achieving their target glycemic control, their target hemoglobin A1C on metformin monotherapy, when we feel that there's no other improvement that we can get to in terms of their lifestyle, then I'll often suggest that we start insulin at that.
So from monotherapy.
From monotherapy.
Right.
Often the conversation goes to sulfonylurea because there's a resistance to insulin with the patient.
Sure.
And I'm fine with that as long as the patient's engaged and they're going to work with me. But I would rather go to insulin because insulin is the best way at controlling glycemia. So 10 units of NPH at night time, that can be protophane, it can be humulin NPH, both are the same. Get them to check fasting glucose in the morning and have a target in mind of 6 to 8 millimoles per litre. And if after 3 consecutive days of doing that, the target isn't being achieved, so they might have 9, 12, 9, I would then get them to add 2 units. So then their 10 units becomes 12 for the next 3 nights. And they keep doing that until they get their fasting glucose within the target range, and they stay there. You can, if somebody's especially large and you're not touching the sides with that insulin dose, jump up by 5 or 10 units in an assisted way. And that's something that can be done either over the phone or with an email with an engaged patient. Practice nurse can help with that. It's just having someone at the end of the phone, a friend to call. Am I doing this right? Should I be increasing? Otherwise, you have inertia from the patients and they don't increase the dose. It's really important when you're starting someone on insulin to talk about how to recognize hypoglycemia and how to treat hypoglycemia. I think it'd be dangerous not to do that. And of course, I'm assuming that education on how to check capillary glucose has already taken place. And I don't know about other regions in New Zealand. I know that the Auckland region pathways are based on what's happening down in Canterbury largely, but our pathways are very good at talking people through this.
That's great.
Coming towards the end now of the slides I prepared, any talk on type 2 diabetes nowadays includes a slide or two on bariatric surgery, and youth type 2 diabetes, or young adults with type 2, is an area that's not accepted from this. And there are a number of studies now. This is probably one of the largest ones, with a couple of hundred patients who were followed up for 5 years at least after having had bariatric surgery at a young age. They had a Roux-en-Y gastric bypass, and that's what the graphic illustrates: the reduction in size of the stomach, the reduction in length of the small intestine, leading to a smaller receptacle for food, so you feel fuller quicker, and then a smaller surface area for absorption of that food. And the plumbing is as illustrated. So they had these operations when they were young. Their body mass index reduced substantially, but still, these were very, very big people. BMIs of 58 falling to 42. 42 is still, in my books, that's still quite a big unit. And in those individuals in this study, and there were only 9 who had diabetes, 8 of those 9 young adults with type 2 diabetes had remission of their diabetes at 5 years at least. Wow. I would usually say in an adult population with type 2 diabetes and undergoing bariatric surgery, we're seeing probably a 70% diabetes remission rate at 5 years. Local data, and that would be in line with our international data as well. The Swedish have the greatest experience, and they're showing around a 60% remission out to 20 years, I think, after bariatric procedures. Okay. Far better than any other intervention to lose weight. It's challenging when you're talking about a very young population, issues with consent, access to a surgeon willing to take on these young adults who are in our funding models very often in the paediatric service, and who funds that, and especially when there are plenty of people within the adult service who would qualify for a funded operation. Yeah. And I suppose it's not for tonight to decide who gets access to that, but it's always an option for some carefully selected individuals.
Sure, yeah, that makes sense.
So just before we finish and open up to more questions, the agenda as published is demonstrated there, and I thought we'd just go through that. What are we doing well? Well, I think we're starting to count and get an understanding of who's got diabetes in New Zealand. It would be better if we could easily discern who's got type 1 and who's got type 2 diabetes. Yeah. When I last had access to the diabetes register, would have think been 2014 data, and I think there were a significant number of patients in my DHB catchment that we just aren't seeing. There are many thousands out there for everyone who is engaged in our young adult service. So it's quite frightening. There is an epidemic out there. So I'd like to improve identification and access, actually getting out there and looking for them. But it's very difficult to talk about screening and otherwise well in a healthy population. How should we approach young adult people at high risk, or those with prediabetes? That's all to do with screening appropriately those with a strong family history, those who are obese and overweight with acanthosis and polycystic ovarian syndrome, and how should we approach those with prediabetes? It's all about healthy eating, lifestyle, weight reduction, increasing physical activity. What works well? Unfortunately, in young adults with type 2, it's more challenging. There's not one thing that works especially well. I think we do need to continue with metformin, continue with the drugs that we've got. Insulin is the best thing to treat these young adults. How can we improve? I think we can improve engagement with these young adults. We've locally had a number of initiatives to try to get our young adults to better engage with our service. We've moved the clinic out with the hospital, closer to transport hubs, which seems to have helped with some individuals, but not all. We've engaged with our social work teams, and especially those individuals who are maybe involved more with the court system, and these people have got much more of an itinerant lifestyle, having social workers to go out and bring these young adults to a clinic, and find that works well. But that's expensive. It works for a small number of individuals, and it won't work for everybody. Complications are very prevalent far more than we would normally expect in type 2 diabetes. Screening and management of those is the same as it would be in type 2 in older people. We just need to be more aggressive and more on the ball with that. And don't be lulled into a false sense of security. I like to see my young adults with type 2 diabetes at least every 6 months.
Sure.
I'd like to be able to see them more often than that, because they are going to progress more rapidly. Long-term outcomes are dismal. I've got a number of young adult patients who already have end organ damage, who already are approaching end stage of that end organ damage, and they're second and third generation who have suffered that fate. We sometimes see these patients, we joke, we catch up with them only when they come to visit their parents in the dialysis unit, and we know that's exactly where they're heading, and it's soul destroying. It'd be nice to try to break that cycle and have an effective intervention in these young adults before they get that way. I think it has to begin in childhood, it has to begin even in utero.
So what I'm hearing you saying, we've had a couple of questions through on ideas about this, and particularly in primary care. Obviously you're working in a slightly different setting, but any role that you've seen working, any program that you've seen working well in terms of nurse practitioners or other initiatives to improve engagement? You've talked about social workers, which is useful. Is there anything you've seen, any tips you can pass on?
Other than very resourceful and dedicated individuals, practice nurses with an interest in diabetes who take it on themselves to be very forceful with their patients and work as hard as they possibly can to ensure engagement. There are one or two individuals who spring to mind. Sure. I'm not aware of any PHO-led initiatives, and that could simply be my bias because I'm not working in that environment. I would welcome any comments from our listeners on that. I'm keen to learn how I can help with that.
Sure, so it's a challenge faced across all levels of care.
We're all in this together.
Yeah, sure, okay. Motivational interviewing, any experience with that in terms of facilitating behaviour change, lifestyle change?
I think all of these tools are useful for me. I think it's always that the individual has to be ready for change, and you can give all the motivational intervention that you can possibly imagine. They're not ready for change, and it's very difficult when these kids are worrying about their education, the domestic violence at home, they maybe don't know where they're going to be sleeping. It's very, very difficult for them to then prioritise healthcare, and these are issues I come up against over and over again. They're barriers to care, and I have absolutely no control over them.
Understood. Yeah, not easy.
No, definitely not.
No. There's a few more questions. Shall we work through them as we go?
Questions.
Yeah, I know we've had a bunch of interesting questions. I guess one sort of area that's popped up is regarding treatment of women, or young adult women, who might be at risk of or trying to conceive. Would you consider managing them kind of proactively by starting metformin?
So anybody who has diabetes, young adult or older adult population, I would consider metformin as soon as a diagnosis is made. I know that the New Zealand primary care guideline talks to using lifestyle intervention, exercise, weight reduction for the first 3 months, reassess, and if the hemoglobin A1C is not improving, then to use metformin. I think the benefits from the UKPDS study with respect to early treatment and reduced all diabetes complications, both in the short term and also longer term, is too difficult to ignore. So I use metformin immediately.
Straight away.
Yeah, we know that metformin is safe throughout pregnancy, provided, of course, renal function is, and the dose is appropriate for renal function. In terms of the pregnancy and pre-pregnancy, whether we're talking about somebody who's a young adult or an older adult who's looking to become pregnant and they have diabetes, we know that comparing pregnancy outcomes both for mum and for baby in somebody who has diabetes, those outcomes are going to be more complicated than someone who doesn't have diabetes. But if we then look at the women who've got diabetes and split them up with respect to what their glycemic control has been, those who've got the best glycemic control are going to have fewer complications, both maternal and fetal complications, compared to those who've maybe got the higher hemoglobin A1C and the poorly controlled blood pressure. So it makes...
So really focusing on that glycemic control right throughout.
Absolutely, and even before conception, we want to have the hemoglobin A1C as good as it possibly can be, ideally at 48 to 53 range before we throw away the contraception and going for it.
Yeah.
Don't forget about the making sure there's folic acid on board there as well beforehand, because there's probably a higher risk of neural tube defects.
Sure.
In addition to other teratogenicity of type 2 diabetes periconceptually.
There was a particular case question. Someone who saw a 30-year-old female, so slightly out of the age range that we're talking about, but 8 weeks pregnant, urine dip with glucose, and BSL was 8.2 on a sort of spot test. HbA1c requested but not available yet. Would you consider that to be physiological or indicative of GDM in someone, I presume, who didn't have known diabetes before now?
Yeah, I think that I would be sitting on the fence. I don't have enough data there. I need to see what the hemoglobin A1C is. I want to know a bit more about the background of that patient and what's her phenotype. Is she a big early day? Is she got acanthosis? Is there a family history? There are other reasons why you can have glycosuria in early pregnancy.
Right.
So I would be...
So it wouldn't be an automatic. You'd be considering all the factors together and manage.
And definitely working her up in the conventional way and using the well-published guidelines for the diagnosis threshold of gestational diabetes.
Yeah, sure. No, thank you. That's great. I think we've talked a little bit about the triglycerides. Someone was asking for a repeat of your advice with the statins and the fibrates.
Yep. So
I guess that was...
I framed the answer with respect to my recent experience this morning of my patient who was probably the more extreme end. If I had somebody who was free range in primary care, not in the hospital, not yet got her pancreatitis, then I would probably use combination treatment. Probably have a threshold, double figure triglyceride, I'd use combination with fibrate and statin. If it was under 10, I'd probably just try using the statin with improved glycemic control. Often, if you didn't use any lipid lowering therapy at all, improving the hemoglobin A1C is going to improve the lipid profile in these individuals. Anyway.
So that's sort of the mainstay,
exactly,
as well as doing everything else.
Yeah.
Got it. Just looking through, would you... sorry, while I pull up these questions. We've talked about retinopathy screening and with the risk being greater in type 2s in young adults, as you've talked about. So would you consider enrolling in the annual screening in the way that you would with...
Yeah, so the retinopathy risk is proportional to glycemia.
Right.
So those individuals who've got very high hemoglobin A1C are far more likely to develop retinopathy than those who've got well-controlled diabetes with a hemoglobin A1C at target. So yes, we've shown data that these young adults with type 2 are going to have more aggressive retinopathy and they're going to develop retinopathy maybe at a lower threshold. That's extrapolation, demonstrated that, but it's implicit. We still do annual screening because that covers those most at risk. For the majority, with moderate control or very good control, we could probably get away with biannual screening.
Right. Okay.
So the reason why it's annual is because we're based upon a 12-month cycle, also because the programs are not sophisticated enough. My take on it, they're not sophisticated enough to work out who needs a longer or shorter screening interval.
Sure.
So we
go with the safest
cover
minimum.
all, go with the safest minimum.
Got it. Yeah, no, that makes sense. There was another question here about the role of C-peptide in differentiation and whether we should be using that.
Okay. I see a lot of patients who are referred at diagnosis with C-peptides that have been drawn in primary care, and I would probably do far fewer C-peptide levels myself. C-peptide, of course, is released in equimolar concentrations to insulin. It's part of the peptide chain. When insulin is translated, it gets folded and then gets cleaved into the insulin molecule and then the C-peptide. C-peptide is a longer and more stable half-life within blood, and so it's a marker of insulin secretion and insulin reserve. And if we think of people who've got type 1 diabetes with very few beta cells, reduced insulin reserve, we would expect a lower C-peptide to be present compared to the classically those individuals who are more insulin resistant phenotype with type 2 diabetes. They would be expected to have a higher C-peptide, indicating hyperinsulinemia and insulin resistance. Often when you do it, it's a grey area. It's influenced by whether you're in the postprandial state or not. It's going to be higher if you've just had a carbohydrate load. And it can also be confusing when you have a young adult patient who's insulin resistant because of their pubertal stage, etc. They've got a degree of insulin resistance. They may also have a degree of insulin resistance because there's a family history of type 2 diabetes, or they may also be overweight. We've got rising incidence of overweight and obesity in kids. These kids also get type 1 diabetes. So it doesn't often help to differentiate.
Specific,
I think still do it when there's a question. I do more autoantibodies and take a careful family history and examine the patient and make my decision based upon all of these features.
That's part of the picture.
Part of the picture, but it's not going to be helpful in everyone.
No,
it's also relatively expensive and hard to interpret sometimes. So, and definitely don't check insulin levels. I hardly ever check an insulin level.
Okay.
And see a lot of people with insulin levels coming in. It's probably not going to add very much.
Oh, that's good advice. Regarding the, there's a couple of questions actually on contraception. Any advice particularly on contraception that you
for most,
suggest?
Oral contraceptive pill is fine. Always got to think about the risk of worsening hypertension. Some girls put more weight on the pill, whether you get diabetes or not. That's recognised, and there's the venous thromboembolic risk with that. The triglyceride issue, any estrogen, oral estrogen can pop the triglyceride levels up further. So if you're kind of counterintuitive to be trying to lower triglycerides and giving something that's going to
bump it up.
The estrogen. Thinking about that, the options would be the either Jadel or the Depo Provera. The other option, which I suggest quite a lot, is an IUD. We used to always think that would be relatively contraindicated in nulliparous women, but I think it's relatively well accepted now that that's no longer the case, and it's actually very well tolerated. A lot of people don't like the idea of it, but when they learn that they don't need to take a pill and they don't need to do anything for their contraception for a long period of time, it's actually a very good option.
Acceptable option, Okay. A few questions on the population of patients with mental health issues. And they do present a challenge. They're recognised as being at high risk in the new guidelines. Any particular advice in this population?
Phone a friend, get as many people on board as you can help with. I don't have all the answers. I have had a few young adult patients. Fortunately, they have not been difficult to manage, who've had quite challenging metabolic response to the atypical antipsychotics. Of course, they provoke a lot of insulin resistance and weight gain, and it can be very challenging. You have to use big doses of insulin. But I think you just need to involve as many agencies as you can, and especially in the community dwelling young adult with mental health issues, I would definitely be involving the community mental health teams and trying to link in with a secondary care young adult diabetes service to help with that.
No, that's useful. Thank you. Challenging population.
Very much so.
I guess sort of getting at what we've been talking about and the difficulties with engaging the population. Are there any, in your experience, any measures that have worked well, particularly when you've got a situation where there isn't necessarily insight or engagement from the parents as well? Any tips on engaging the wider family?
I think we've all had challenging patients, and it's often a difficult conversation to know where I have a right to talk to someone else's family, someone's family, if they aren't giving me consent to do so. So I'll always make sure that I'll ask my young adult patient, is it okay with you if I have a chat with your mum or your dad or your auntie that you're living with, or maybe have a word with your boss if you're having problems at work. Whenever I've asked, I've never encountered a no, you can't. But I always take care to frame it to say, look, we've been giving this a try. Your diabetes control isn't as good as we would like it to be. You're obviously engaged with us. You want it to be better, and what we're doing isn't working. let's see how else we can
Right.
look at that. Who's at home that can help you?
Yeah.
So I think as long as you're open in your approach, that can help.
Sure.
Of course, the opposite can happen. They can say no, and the door gets shut. I don't have the answers for what to do there.
Worth a try, though.
Worth a try.
Yeah. No, that's great. And of course, people mentioning smoking and alcohol use in this population. Yeah.
Absolutely. That's
need
to
address that. Yeah.
Yeah.
Okay. I think we're having a few thank yous, and which is always encouraging and nice.
It is, yes.
And I think we probably are coming towards the end of our time. I apologise if we haven't got to particular questions. I'm just scrolling through some comments about the use of school nurses and practicing nurses who will obviously be great help in a primary care setting. And just sort of checking metformin and breastfeeding mothers, just a quick
no contraindication.
No contraindication as far as I'm aware. Yeah. There was another question too about the value of additional 3 times daily dosing of metformin versus twice daily, and in your experience whether that adds enough of a benefit.
Probably non-additive. We can show studies that will demonstrate no advantage comparing twice a day with 3 times a day. Other studies showing that there's a small advantage that's not really a clinically relevant change. I think for me it comes down to what the patient's going to remember to take. And if they can't take more than 1.5 grams and they want to take that 3 times a day, that's fine. If someone wants to take 1.5 grams twice a day, they're tolerating that and they've got good kidney function and they're a big unit, that's also great. I'm not going to change that. Sure. Generally speaking, unless somebody's very, very big, and very big I would consider someone over 120 kilos, I'm going to go for 1 gram twice a day and probably stop there.
Stick with that. Yeah, sure. No, that's a nice rule of thumb.
Not necessarily based upon any hard science.
Yeah, sure. Okay, well, look, I think that probably brings us to a close. So thank you very much. It's been really...
Thank you for having me. I hope that it was useful.
Yeah, and we'll make the slides available on the website. And so they'll be there for reference for people to look at. So thanks again.
Yep, and my email address is on the end there. So if anyone's got any specific questions or anything you want to ask me, please do be in touch.
Oh, that's wonderful. Thanks very much, Stephen.
Okay, thank you.
Okay, good night, everybody.
Bye-bye.